Okay, Dr. Nesin, back to you.
All right, thank you, Matt. So as I said, we'll get started with these slides and look forward to your thoughts and questions as we move forward. So here's the updated numbers as of yesterday in the U.S., or this is a set of updated numbers. It's a bit of a moving target, but 108 million plus cases so far in the U.S. of coronavirus, and sadly, well over 1 million people have died. Long COVID we know is a concern. Long COVID is hard to diagnose, a little hard to define still. There's emerging literature on defining it. It's estimated that 10 to 20% of people who get COVID will get long COVID. And I think there was just a publication this week on the actual number of people in the US who've had long COVID, which I think was estimated at 18 million people reported having long COVID. So that's imprecise and not using any kind of consistent diagnostic criteria. But there are people suffering following COVID infection. I think that's the important point for us to understand right now.
Yeah, and again, I'd emphasize it's important because some people don't think COVID's serious now and they don't think about it, but long COVID is real. I hope within the next year there's actually going to be some diagnostic tests that will help us. There's been some interesting literature recently, but not really there yet.
And a reminder for all of the data we're going to be looking at today, the data on COVID cases is challenging because home testing is so widely available, and up until recently has been freely available, and those cases don't necessarily get reported, and so that data is challenging now as well. In Maine, over 300,000 cases and over 3,000 deaths. I think the most recent death from COVID was on September 20th, unless one occurred in the last 24 hours. So we're still seeing that, unfortunately, in Maine. And here's the pattern of daily cases across the United States. And this is for the entire duration of the COVID pandemic. And, we can see, the Delta wave, the first winter season, the second winter season, and then the Omicron spike in the middle of that, and then a couple of other surges, and what had been a fairly prolonged time of lower case rates, and then, as we've all been reading about in the media and hearing about, some rising in case rates starting in August and continuing into September up until now, really. Although there's at least the case rates, the most recent trend is down a little bit.
And probably just worth emphasizing that if you looked at those two big spikes, they're in the winter, and we're rolling into the winter time, and we know that's when we see more respiratory viruses. This week it's been lovely weather, but it's cold weather is going to come.
Right, it's not gonna stay like this, we don't think. And this is the the trends in deaths in COVID over time as well. Again, we can look at those winter seasons on this one as well, and then both we've gained immunity through immunizations and through infections over time, with some protection associated with that. And I think the most recent variants have been fortunately less deadly than prior waves, and we've seen generally a good trend in that regard. But I'll show you a little bit more detail on COVID deaths as well as we move forward through this. This is hospitalizations over time, and just seeing comparing Maine in blue to the U.S. overall in orange, that Maine has fared well in the rates of hospitalizations, notwithstanding the vulnerable populations that we have, especially elderly population in a state like Maine. We've done well, especially during the the most deadly surges in COVID, and again, in more recent months, we've seen sort of all of this flattening out, and that's been true for Maine and US as a whole. And here's just some general trending. Test positivity had been going up in August and through mid-September, and then began going down a little bit. This is from the CDC. ED visits reflected that as well. The hospitalizations appear to have plateaued a little bit nationally, and deaths, which is a lagging indicator, are still on the rise as of the most recent data across the country. So who knows where this is going to go in the short term, but as Dr. Sears said, with winter coming, we expect all of these numbers to rise again.
Yeah, and I would add, just from a Maine perspective standpoint, we have been seeing some outbreaks in long-term care. We've seen a couple of healthcare associated outbreaks, and schools back. And although I have not seen a lot of really complete data for schools, we suspect that we'll start seeing significant respiratory tract illnesses coming up soon.
If my granddaughters are any indication, they both had respiratory illnesses testing negative for COVID so far, but since school started. So here's the main trend in COVID cases all time. That weird blue spike, I think, was when there was a delay in reporting and there was a dump of data all at once at that point. But otherwise, similar trends to the national trends, with this uptick more recently, way over here on the right. And then just to shorten the time duration so that the more recent trend is more apparent, although very spiky because our numbers are very low overall, because of the population of the state and because our relatively low case rate compared to the rest of the country. Still, you can see that upward trend occurring through August and mid-September. So that's a concern, even during good weather. Never mind when the bad weather's coming. Sorry, Stephen.
No, that's okay. I was just going to say, I think sometimes we get hung up looking at rates, and when you got small, the absolute numbers have been real, with both, as you saw, there's increase in deaths and increase in hospitalizations. It gets pretty drowned out when you look at a rate, and depending on what your denominator is, and clearly lots less than what we've seen in the past, but that doesn't mean we're not seeing an increase.
Yeah. And here's our hospitalization trends. Overall hospitalizations, again, you can see it trending up in August, getting to what Dr. Sears was just talking about. Those are pretty sick people if they're ending up hospitalized for this. Some of them in critical care, not many on ventilators, thankfully. But hospitalizations, are a sign of pretty severe illness, and that certainly has been trending up over the last 4 to 6 weeks. So really important consideration as well. And again, the numbers are low. The last person who died from COVID this is a single person on September 20. So hard to see trends in death in Maine with these numbers, but we certainly nationally see an upward trend in deaths. And because this remains a concern both for individual and public health, then it's important that we do what we can to protect vulnerable people, and we all know what those things are. It's vaccination and limiting spread to the extent possible. So overall, Maine's COVID experience remains very good compared to the rest of the country. Case rates, as Dr. Sears said, are not the whole story, but we do have the third lowest case rates, despite a very old population, the 9th lowest death rates in the country. We have the 9th highest testing rate, despite being a pretty rural state and people with not a ton of resources or transportation options. And we have the 2nd highest vaccine rate, although within that vaccine rate, with each subsequent round of available vaccines, Maine and the country has seen a steady decline in the uptake of those vaccine options. So the original, we are well over 90% of Mainers, eligible Mainers, which is almost everybody, who've had at least one vaccine. But as far as the bivalent vaccine, for instance, we're in the mid-20s, around 24% of eligible people who've had the bivalent vaccine. So that's a concerning trend, even though Maine overall is among the best in vaccine rates. This sort of diminution of uptake as each subsequent vaccine has become available is a concern. And as this virus continues to mutate, it behooves us to have as much immunity as possible in place in case a more virulent, more contagious strain of the virus emerges. And it's concerning that the uptake's been so low on the most recent vaccine availability.
And I think as we move from, having been in an epidemic to an endemic state, people tend to, I don't want to say they ignore, but they're just sort of moving on and not thinking about this as much as we did. Doesn't mean we're not going to see it. It just means that the overall awareness has declined. And hopefully, one of the things we can emphasize here is it's time to, maintain everybody's awareness, get people more engaged in thinking about immunizations, and not only COVID, but also influenza and the new RSV vaccine.
Yeah, that's a good point, Dr. Sears. I wanted to jump in with a question too. So we have the second highest vaccine rate in the country, which is incredible. And then Dr. Nesin, you said, but our uptake on the bivalent vaccine was 24%. So what changed? And maybe it gets to some of what Dr. Sears just said, but how did we do so well with the initial vaccine rollout and uptake people versus, the bivalent vaccine and now? What did we do well before that we need to keep doing?
Well, I think people were intensely engaged with the pandemic, during the first year or so, and especially, with all of the concern about the disease and its potential complications, people were pretty eager to get vaccinated when the first vaccine became available, and it was very, very effective. As time has gone by, this is my opinion. Both the dynamic that Dr. Sears just described, which is, people are tired of it. Their lives are less disrupted by it. It's less the lead story, certainly not the lead story on the news any night anymore, or on the front page of the newspapers. It's kind of faded into the background, and so people are less inclined. I think even people who would be inclined to get the vaccine are more unaware than we think that there's even a new vaccine available. That's a concern. And we've continued to see ongoing politicization of public health, especially around vaccines and around COVID-19. And I think that's somewhat contributed to the degradation in vaccine uptake as well, despite the fact that, with our huge experience with these vaccines now, we know they're extremely safe. Whether it's the mRNA vaccine or the Novavax vaccines, they've been very, very safe, and they remain effective at reducing the risk of severe disease, hospitalization, death, and likely reduce the risk of long COVID, although we can't say that definitively yet, I don't think.
Yeah, and the only thing I'd add to that is if you think back the times before the pandemic, we had the same problem with uptake of influenza vaccine, because people either didn't think it was a serious disease, didn't think it was around, didn't think it affected them. And we we had really strong public health campaigns to try to increase influenza vaccine uptake, and we were able to get there in many ways. But there's always more opportunity. I think we're in that same place in many ways with the COVID vaccine, and importantly, we need to try to emphasize and re-engage people in the conversation to get out and get really their updated vaccine. It's not being called a booster anymore. It's the updated vaccine. If we think about it, we don't call the influenza vaccine every year a booster. We say it's your yearly influenza vaccine, and that's really this new language really does say it's either the updated COVID vaccine or the 2023-2024 COVID vaccine. And the more we kind of make this more routine and expected and necessary for respiratory tract health overall, I think the more we can move these numbers up. But it was a pretty significant decline in overall immunization when the last vaccines came out.
Yeah, I'll let you all keep going, but I think that's a really important point on messaging, Dr. Sears, is people thinking of this as a yearly vaccine, right? So if you've been vaccinated with the primary series back in 2021, whatever that was, your protection has waned significantly over time. So I wouldn't think I'm still protected by the flu because I got vaccinated for the flu 2 years ago. You know what I mean? I think that's a really important point. All right, I'll let you all keep going along here. Thank you.
Thanks, Matt. That waning immunity is a really important point as well. Thank you for bringing that up. Just showing some data comparing vaccination rates for Maine in blue, for the USA in yellow, and for Alabama, which is a state that's had a lower vaccination rate. So I chose it from among the states with lower vaccination rates, and showing that correlation of these vaccination rates with hospitalizations for COVID over time. You can see Alabama had pretty high rates of hospitalization during those surges of COVID. The USA was in between, and Maine had lower rates of hospitalization in all three of those surges. Those two things, those vaccination rates and those surges in hospitalization rates are not unrelated, of course. Those two things are linked in really important ways. This is the current COVID community risk level by county. So we are seeing this uptick overall, as Dr. Sears said, compared to the pandemic times of this infection. Things are better overall, but you can see scattered around the country areas of more concerning rates of infection. And in New England, that includes New Hampshire and southern New Hampshire and Vermont, and parts of eastern New York on the border of Vermont. And these things fluctuate over time, and Maine could be included in that at some point, especially in the winter months. This is the variant trends, just to demonstrate how rapidly and continuously this virus mutates. These are all Omicron variants that we've been dealing with for quite a while now. But over pretty short periods of time, we see the variants that are present changing pretty rapidly. The last two bars over here on the right are sort of projections for where we're going with variants. And really, to me, this slide, as a family doctor, not as an epidemiologist or public health expert, but as a family doctor, this just motivates me more to make sure I'm up to date on the most recent COVID shot vaccine, because I want to maximize my protection in the instance, as I said, of either what we anticipate, which is a surge in cases as the winter months approach and the holidays, et cetera, and a more virulent contagious strain. I want that immunity in place, prior to that happening, should that happen. You know,
Yeah, and the only thing I'd add to that, and I think we all know this, is variants are the norm. This is what we're going to see, and we'll see a continuing evolution of the virus, just as we do with other respiratory tract viruses. And and we started, if you just sort of go back, we had Alpha, then we had Delta, then we had Omicron, and now we've got all these subvariants of Omicron, and that's really what we're talking about here with the XBBs and you can see the EG 1.51s and up to where we are with what's called BA 2.86, all of which gets to be a sort of numbers and letter soup. The important thing is these are variants of the Omicron, which has been the most consistent strain we're seeing. But that's not to say another strain might not come up, because if you think back to the time when Omicron came, that was originally identified in South Africa, and all of a sudden it was in the United States, and we saw incredible spread. And we're on the lookout for these, but keeping and maintaining immunity broad-based is going to help when the next one does come up.
Yeah, speaking about being on the lookout, this one got a lot of coverage over the summer. The BA 2.86 variant, or Parola variant, which had a very high level of mutations, and it caused a lot of concern about its potential for overcoming immunity, from vaccines and from prior infections, and whether it might cause more severe disease and overcome our ability to battle it. More recent evidence indicates that it's likely as susceptible to our immunity as other variants, and still not a significant cause of disease. I have to admit, I forgot to update this data. This is from a couple of weeks ago, where it had been identified in people in 9 states, and in wastewater in 1 additional state. And Dr. Sears, I know you've been traveling and out of the country, so I don't know if you have any updated information on this variant.
10 states was the last I saw,
Yes.
but again, the data lags on this. And I think I'm glad you mentioned wastewater, because that's actually become a very useful tool around the country to sort of look at and monitor trends. I was out of the country, and the one thing I can say is a lot of people were coughing a lot of the time, especially in the airports. So I've tested myself.
And it's felt likely that the updated vaccine will be effective against this variant, and this variant doesn't appear to be the concern for public health that it had the potential to be, given the number of mutations that it included. And I guess that's a fortunate consideration. So here, an update on the 2023, what's being called the 2023-2024 COVID vaccine. I think we are hoping that COVID vaccine will be like flu vaccine and require simply an annual booster, but because we can't predict where variants will go, we can't guarantee that there, between now and next fall, that there might not be the need for another COVID vaccine. But right now, we'll label this a 2023-2024 COVID vaccine. It was approved in early September by the FDA and then the CDC. It is recommended for all people aged 6 months and older. Again, vaccination remains the most effective way to prevent illness or severe illness and hospitalization and death. It likely reduces, as I said previously, the risk of long COVID, which is a really important consideration. Almost 700 million doses of these vaccines have been administered in the US alone, and only 4 documented serious adverse events. It's a very, very safe vaccine, and we can, those of us who are clinicians, can confidently reassure our patients, for themselves, for their children, for their infants, for pregnant women, that this is a very, very safe vaccine to get. It's available now, and this is a website, vaccines.gov, where you can find a place to get the vaccine near you. I tested this last night in all kinds of pharmacies, around where I live, that where I can get it, and FQHCs and health systems have access to it as well. to provide this vaccine. So, and there is a program for people who don't have insurance and can't afford the vaccine to get vaccinated as well. Before I move on, Dr. Sears, do you want to add anything about this vaccine?
No, the only thing I'd add is that I'm scheduled to get mine tomorrow. So it's like, I always think it's important that we are, we have to walk the walk also. So
absolutely. I'm calling this afternoon to schedule mine. Actually, I have a few hours free this afternoon after this, so that's when I'm planning to call to set it up.
Yeah, we have a hand raised here from Courtney Dillingham. So Courtney, I'm gonna ask you to go off mute and you can go ahead and ask your question.
Okay, thanks, Matt. Just speaking about the vaccines a little bit, there's a lot of like word on the street, I guess, out in the greater community throughout the US. Access to vaccines, do we have a good pulse on how well or how great the access to vaccines here in Maine is? Like, are people having difficulty with their insurance trying to get vaccines, or like our long-term care facilities and acute care facilities, are they able to be well stocked? Does anybody have any information on that?
I don't have information on whether people are having trouble with their insurance covering vaccines at this point. Although I would say both, they shouldn't, and it wouldn't be surprising if they do, right? Because of the way these things often work. And
I'd say, Noah, that's correct, that it's not supposed to happen, but it has, and that anybody who gets charged for a vaccine needs to push back on that. I don't know about the supply in nursing homes. I think it's adequate. I certainly know the pharmacies have stepped up and have made this readily available.
Anecdotally, I can say I found a lot of appointments, at least in the Brunswick area. So I think it might depend on areas of the state. And then I know someone shared in the chat in Yarmouth that it is actually harder to find right now due to supply. And then I would just flag 2 articles in the Portland Press Herald, I think this past week, that talked about some constrained supply, but that it should be getting better soon. And then there was also a story on this issue of people paying for COVID vaccines when they shouldn't through insurance. And as Dr. Sears said, if that happens to anybody, you should seek reimbursement, because that is not supposed to happen.
And that's what I was going to add, is that our experience in Maine has been that although initially there may be areas or pockets where it's harder to get the vaccine than we might like, those have been remedied with past vaccines, COVID vaccines, pretty rapidly in the state, and they've become pretty readily and quickly available. And that's what I would anticipate with this as well. And fortunately, we have a little bit of time before the really cold weather hits, and I think most people will have opportunities to get vaccinated well before that.
Well, that brings a question I had on just logistics. So where can people, I think you have vaccines.gov here, is that a national site? Is there a Maine specific site that people should look at?
That's a national site that certainly has Maine data in it. So you can put your zip code in and find vaccines near you. I think calling your primary care practice, calling federally qualified health centers, which are part of the distribution of this, calling the larger health systems, Maine Health, Central Maine Health, Maine General, Northern Light, all ought to be ways for people to access vaccination.
Right. And I'm seeing some things in the chat about how it is actually showing up that there are no vaccines in the area when they search their zip code. So I think it does depend on areas of the state, and that points to some current shortages. So I think that's something we need to figure out.
Wow, 100 miles. That's concerning.
Yeah. I mean, I know that Walgreens and Hannaford, which are pretty well distributed throughout the state, have had adequate supply. And both for, I know from one place where they've been handling a lot of walk-ins, and others where you can just go online and schedule, and it's schedulable within a week.
Yeah, and the other thing I'd add about this COVID vaccine is it can be given at the same time as an influenza vaccine. If it's not given at the same time, there's no specific waiting period required. You could get it the next day if you wanted. So I think that's important. And Dr. Sears, I'll ask you this question: if you get COVID tomorrow from your travels, from all the people coughing around you, how long would you then defer getting the updated COVID vaccine?
You could actually get the vaccine. So if you're asking me, this is now my personal opinion. For me, I'd probably wait about 2 to 3 months. And that's really just looking at how I'm going to get the maximal continuous immunologic response available.
Yeah, that would be my thinking too, that I could extend my immunity by taking advantage of the short-term immunity, relatively short-term immunity from the illness for a couple of months, and then getting the vaccine to extend it beyond that. So, masking is still, if you have a good mask properly used, you can protect yourself and others. So if you've been exposed, it's good to wear a mask to protect others. If you want to maximize your protection, or you want to protect people with whom you come in contact that you care about, whether it's coworkers or loved ones, if you're at increased risk for severe illness, if you're not up to date on vaccines and you don't have that protection, if you, in the course of your day, you're exposed to a large number of people, especially indoors, and then when traveling on buses, planes, and trains, there's sort of an intense packing of people in those circumstances, and a mask could be considered there as well for protection. Again, especially as we're seeing this uptick and we're entering the winter months. So very quickly, the respiratory syncytial virus vaccine, the RSV vaccine, has now been approved for people like me, age 60 and over, because it can cause severe illness and hospitalization in older people. And it has been approved for pregnant women, pregnant people between the ages of 32 and 36 weeks gestation. And the point of that is that by the pregnant person getting vaccinated, that they will convey that protection to their newborn through the course of time when newborns are susceptible to RSV, which can be a very significant infection and even life-threatening for newborn infants. So this is an important new respiratory virus vaccine. This has not been previously available. And I'll be getting this one as well. And then finally, of course, the influenza vaccine, which is recommended for all people, like the COVID vaccine, 6 months and older. And this season's flu vaccine is now readily available, and flu, we may not be thinking about it as much in the context of COVID, but it causes lots of hospitalizations and deaths every year, and largely those are preventable through vaccination and the kind of protections that we've talked about with COVID, but not exposing people unnecessarily when we have respiratory symptoms, and especially vulnerable people. So
I was going to say, I would just say it's like we are in a unique situation in public health and preventive medicine, with 3 vaccines available for the most significant respiratory tract infections. And if we are able to promote this and have this available for individuals, we could dramatically decrease the types of illnesses that we have seen for many generations now. Overall, I mean, obviously not COVID for generations, but RSV and influenza are significant diseases, and especially for those who have significant underlying illness, those who are over 60. We'll see as this gets rolled out whether those recommendations change, but that's where things are at the moment. But it's a unique time in the sort of the history of vaccines, clearly for respiratory tract illness.
Right. Thank you both for that overview. I certainly have some questions. I want to encourage other folks to ask questions as well. So I'll kick it off with one of mine. But as I do that, think through your questions. If you have them, use the hand raise function, and I'll ask you to unmute and you can ask your questions. So I wanted to talk about the data and the wastewater and at-home tests. I know, Dr. Nesin, you said it's a little more difficult to gauge the number of cases because people are using at-home tests. And then one of you mentioned that wastewater is an increasingly useful tool. What is our wastewater testing infrastructure like in Maine right now? How significant is it? And what would you like to see moving forward on wastewater testing?
I'll take a first stab at that. There is at the CDC, both it was funded originally through Maine CDC, but is now funded through federal CDC, wastewater testing in a variety of different locations. And again, as a early warning system, looking to see whether COVID is in the community, because it appears that before you might start picking up individual cases, you can find it in wastewater. And again, that's just because it is excreted, and therefore it is when someone has been ill or is ill, a marker. There is a web, I think Courtney was out there saying that there is a place on the Maine CDC website where they've got their wastewater overall. But I think it's growing in its usefulness. A lot of people for the last year or two have been gathering information to try to better validate it. It's been used in Europe and other around the globe more than we had done it here. But to sort of put that in the same conversation as the home testing, because we used to count every single case of COVID. And so we'd have, if you remember that we had every day cases. We don't have that anymore. What we really only have is the serious aspects of COVID. So we can count hospitalizations, we can count deaths, the number of tests, number of people infected, far less accurate information. That's why an early warning system like wastewater can be helpful in just giving us an idea of where things are going.
I'll admit that I spend more time than I should at the Maine CDC site looking at the wastewater data, which I find interesting. And it has been interesting and helpful during the course of the pandemic, at least to me. And right. And then the other indicators we have are sort of post facto indicators like ER visits, hospitalizations, and deaths, and tests that do get reported, but there are only a fraction of the actual number of people who get tested. And then the people who never test or even assume that they don't have COVID, who may have COVID, they're sick, but they don't feel that bad, so they don't test at all. And I think that's quite common.
Like for that home test, though, we're able to order them for free again from the federal government. If folks haven't seen that, so COVID.gov can order, I can't remember how many free tests, but those are now available. And my mom recently used that home test to test herself, and she was positive. So useful tool. And just a fun fact, it took her 12 days to test negative. So that 5-day rule, there's a caveat there that doesn't necessarily mean you're no longer positive after 5 days post that first positive test, and to continue to take precautions if you have to go outside.
Although Matt, I think the CDC recommendations for ending isolation are not dependent on a negative test necessarily. So it's more the duration of the time that you're symptom free.
Yeah,
it really goes back. If you look at the viral kinetics, the highest viral shedding numbers are earlier on in the illness, But it doesn't mean that if you're still testing positive, it would be prudent to wear a mask when you go out in public. So if you recall, this has been a moving target over time as we learn more. Started out, everything used to be 14 days, and then it went to 10 days, and then it went to 5 days. But that is an even in the 14-day scenario, there are always people who were testing positive after the 14 days. Some of it was viral particles, but some of it was viable virus. And if you look at it from a population standpoint, there's always going to be some people who are going to remain positive for longer than others. Just that the 5-day rule was based off of the really the confidence intervals of and the bell-shaped curve on viral shedding in most populations.
Yeah, that's helpful context. And it took her 12 days to test negative on an at-home test. But yes, I think that's helpful context to know on the viral shedding. And this brings up another question for me. And again, encourage other folks to ask your questions. I haven't seen any hands yet. The community risk assessments. So I remember when that new assessment came out, but can you share as a refresher for me and maybe other folks, what is that based off of? Like, what is the community risk assessment based off of? If people look at that as a way to measure risk, what goes into those? What goes into that? What does it mean?
But Dr. Sears probably has a better response to that than I do, but my understanding has been that it's both the prevalence and the severity of the virus in the community. Is that right, Dr. Sears?
Yeah, I think that's a reasonable assessment. Again, it's challenging because those were all the original risk assessments were based off case rates. And that's, as we've just sort of mentioned, is less solid information. So it's, but it is a number of both numerator and denominator numbers that the federal CDC puts these out really for. That's the county-based rates
Right.
overall.
Right.
Sharon saying that she thinks hospitalizations are weighed most heavily in that data, which was my understanding as well.
Yeah.
Yeah. Thank you for sharing that. So the other question I had, you had mentioned earlier, Dr. Sears, well, you said strain a couple of times. And so I wanted to make sure I understand what's the difference between strain and variant. Can you explain that for me?
Probably imprecise language by me. That's so it's really variance that we're thinking about more than anything else. And you have to look at each one of those viruses slightly differently because there are different. We know that there are variants within influenza as well as in COVID. There are different strains in influenza. So there's like influenza A, influenza B, influenza C. A and B, the ones that are causing disease. COVID at the moment, we're really saying we have COVID-19, and then we have the variants that have been progressing over the course of our understanding of COVID over the last 3 years or so. So
Gotcha. Sorry.
that's always good because we tend to use language both specifically and in the vernacular, and it's good to be called out on it. So
yeah, and as Dr. Sears pointed out, we've been dealing with Omicron subvariants for quite a long time now, but there's nothing to say that a new variant, I don't know what the next Greek letter that we're going to use is. I think we have to skip one for some reason, but there could be a new Greek letter variant that emerges at some point as well.
Yeah, it would actually, if you go over the history of how we looked at these. We originally called them all by numbers, and that became very challenging for people to understand and follow. And then they started adding the Greek letter lexicons to them. And there were epsilons, and there were others that never really came to be significant population risks, but they looked to be variants of interest, and then variants of concern. Um, and we just have to, right now it's all Omicrons, but Omicron sort of came from, I mean, it didn't come from Delta, but it came very rapidly. Back, it was around Thanksgiving time, in 22. And we saw that was significant, maybe 21 anyway, significant numbers overall. So it's monitored, and there are a number of places around the world that are continuing to look at the genetic makeup of the viruses.
Just to stress too, I think you mentioned this in the presentation, Dr. Nesin, but even though the latest vaccine was formulated against a previous variant, it's likely going to have significant protection against future variants because they're all subvariants, at least right now, subvariants of Omicron. Is that right?
That's right, and that's been our experience with the vaccines so far. And so, will it be perfect protection? No, we don't expect 100% protection with this vaccine, but we don't expect that with the flu vaccine annually either. And yet, for a population of people, there's tremendous benefit to having vaccination and the immunity that it does confer in reducing severe disease and death. That's the reason we recommend both, and why we'll recommend the RSV vaccine as well.
Yeah, and I think I always like to mention when we have these conversations is there's both B cell and T cell immunity, and we generally think of, when we're looking at the antibody responses, that's all basically B cell, and we're pretty sure the T cell response, which is less easy to measure, is as durable, if not more so, and involved in the overall protection. But it's never going to be 100%. But if we can continue to have high rates of at least minimize hospitalizations and deaths, then we're really doing a lot of we're creating a lot of population benefit.
Well, that brings up one quick question that was in the chat. Someone asked if you can share a link to a study or data that indicates lower rates of long COVID for those who are vaccinated.
I did. It's hard. It's from a previous presentation, and it won't let me copy and paste just the reference. So I had to copy and paste the whole slide. So I know it's hard to read, but again, these aren't conclusive. But these studies suggest that there's protection from long COVID for people who are vaccinated.
It'll be hard. It'll be hard to have that answer until we have a better definition of long COVID, because we don't have a clearly defined marker that can identify long COVID. It's a conglomerate of symptoms which may be very different, and there's probably different subtypes of long COVID. So hard to make that for sure. I think it appears that if on the flip side, it certainly doesn't make it worse. Because there was concern that perhaps this was an aberrant immune response of some sort. That doesn't appear to be the case.
So I wanted to ask about messaging again, because I think I've had conversations with friends and family and other folks who they don't know that there's a new boost, or I almost said they don't know if there is an updated vaccine available.
Right.
So I've been trying to, in my conversations with them, clearly show that there's a need for them to get the new vaccine, even though they're, not necessarily considered high risk people. So my question for you both is, and potentially for the audience too here, is how would you best describe the need for the new vaccine to people who maybe just got the primary series, haven't had any additional shots? Because how would you characterize the waning immunity is a more specific way to ask this question. Like, your immunity has gone down X%. I don't know if that's appropriate to say. What would you say to people?
Well, in talking to patients, I wouldn't get into detailed data about this necessarily. I think it's been effective to help them understand that immunity does wane over time, and to compare it to something that is a familiar experience to them, which is influenza. that your immunity, as you said earlier, from last year's flu shot does not protect you for this year's flu. And that now is true of COVID as well. And based on what we know right now, that we have a vaccine that will likely significantly reduce their risk of severe illness or hospitalization or death, and therefore also reduce their risk of spreading it to people they care about, should they get, if they were otherwise get infected, and that these vaccines are proven very, very safe. And so really, my recommendation is there's no downside to getting the vaccine, and there's tremendous potential benefit for you. And we have vast experience with this vaccine in this country, around the world, and even in each of our communities now. And this, with the winter months coming, this is an important way to protect yourself.
Okay, thank you for sharing that. And I'll also just say, I went through, as we were going here, I went through the Maine CDC's vaccine site. So just the maine.gov/COVID-19/vaccines website. And through there, it primarily gives pharmacies. So just to put a finer point on something I think Dr. Sears mentioned earlier, the pharmacies do seem to have at least a adequate enough supply right now. Not to say that it's the best it could be, but just plugging in like Yarmouth, I found an appointment in Gray, which is not, I don't think, too far, but then also one in Yarmouth in a week and a day. So I think that's probably the best place for people to look right now. I haven't gotten anything from my PCP, I don't think, yet on the updated COVID vaccine in their offices. But just to flag, I think pharmacies are the way to go, at least at this point in time, before the supply expands. Well, any final thoughts, comments, or questions from the audience or our speakers?
My final thought was something I already said, which is this is a unique opportunity. We've got, we know respiratory tract illnesses, viral illnesses have always plagued us in the winter months. And not always, and sometimes year round, but the major outbreaks occur in the colder times and as we get indoors. We have never had the opportunity to decrease 3 different diseases and really, hopefully, see an improvement of overall health for a variety of at-risk individuals. So it's unique, and I think that we've spent a lot of time arguing about vaccines. I look at this from the population standpoint, and this is really a tremendous time to be providing protections and help to individuals. So that's, that would be the message I'd try to keep making, that these are unique times and we have a great opportunity.
Yeah, and I know everybody on this call gets it, that we all have a responsibility to spread that message and to make sure that people are aware of the availability of this vaccine and how important it is that they get it.
Great. Well, thank you both so much for doing this. It's been super helpful for me. I'm sure it has been for our attendees as well. And thank you for everybody who came and listened. So we'll end it there. If our speakers could stay on just for a minute afterwards, but everybody else, please go ahead and jump off, and thank you again.
Thank you.